Hello everyone, I'll be talking about causes of GI bleeding. So first of all, GI bleeding can be divided into upper GI bleeding or lower GI bleeding. Upper GI bleeding is usually considered as bleeding which occurs proximal to ligament of Treys. This includes the esophagus, stomach, and the duodenum. And the bleeding that occurs distal to the ligament of Treys is considered as lower GI bleeding, and this includes jejunum, ileum, the large intestine, and the rectum and the anus. So these are the most common causes of upper GI bleeding, and the very first cause is peptic ulcer disease. And if the ulcer erodes all the way into a blood vessel, this can lead to bleeding in the stomach. And also, alcoholism can lead to erosive gastritis or erosive esophagitis. Liver diseases like cirrhosis can lead to esophageal varices. On the left side, you can see a bleeding of an esophageal varices. And due to severe vomiting, the junction between the stomach and the esophagus can tear, and this is called Mallory-Weiss tears, and this can lead to bleeding in the upper GI tract as well. And esophageal cancer, gastric cancer, and also finally, dilophoid lesion, which is a bleeding of an arteriole in the submucosa of the stomach. And here you can see on the right side, peptic ulcer disease. This is the ulcer, and the erosion of this ulcer can lead to bleeding. Moving on to lower GI bleeding, diverticulosis. Diverticulosis is when pockets called diverticula are formed in the walls of the digestive tract. Pressure in the inner layer pushes weak spots in the stomach, in the intestine, to form a pouch, as shown in this diagram. You can see that small pouches have been formed on the walls of the intestine. Merkel's diverticulum, it is one of the most common congenital defects. It occurs when there's a leftover portion of the umbilical cord in a patient. And then there's also ischemic colitis and infectious colitis and neoplasia. The most common neoplasia in the or in the colon is called colorectal cancer. If the patient has a history of weight loss and a family history of colon cancer, we can suspect colorectal cancer. And also inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease, hemorrhoids and anal fissures, and finally aortoenteric fistula. And aortoenteric fistula is a connection between the aorta and the intestines, and of course it can lead to a lot of bleeding it can lead to bloody stools. This is a table outlining the differences between upper GI and lower GI bleeding. In upper GI bleeding, we can see hematemesis. Hematemesis is vomiting up of blood. It can be either bright red or coffee ground in color. If the color is coffee ground, that means the blood has reacted with the acid in the stomach, causing it to turn coffee ground color. And usually in lower GI bleeding, hematemesis is very rarely seen. Melena is black tarry stools. This occurs due to the digestion of the blood. And in lower GI bleeding, this is not typically seen. We usually see hematochezia, which is bright red or maroon blood in the stools. And hematochezia is not typically seen in upper GI bleeding, but if the blood is moving rapidly in the intestines, we can see hematochezia in upper GI bleeding as well. Finally, I would like to talk about how to approach a patient with GI bleeding. So first of all, we have to start with the basics, the ABCs. We have to check whether the patient has an airway, because vomiting can cause asphyxia, and we have to check whether the patient is breathing, and also we have to check for signs of shock or hemodynamic stability. We have to check whether the blood pressure is low, or whether the patient is tachycardic, or whether the patient has cool or clammy skin, which would indicate the patient is going into shock due to loss of blood. And then we have to take a history from the patient. We have to ask whether this happened for the first time, or whether this has happened before, how many episodes, and how much blood the patient lost. Of course, the patient can exaggerate the amount of blood lost, but it's good to ask whether these questions from the patient. Associated symptoms, you have to ask whether there's any abdominal pain, lightheadedness, dizziness, or syncope. Of course, losing a lot of blood can lead to lightheadedness or dizziness. Then moving on to medical history, an alcohol history of alcohol abuse or liver disease can indicate cirrhosis that can lead to esophageal varices. So we can narrow down our differentials based on the medical history as well. And medication list, if the patient is on NSAIDs like aspirin or glucocorticoids, we can suspect a peptic ulcer disease. And also if the patient is on anticoagulants, which is for example warfarin, that can lead to bleeding as well. And finally, we should ask the patient whether they had beetroot or red dyes, because that can manifest as red color stools, which can indicate and which would indicate bleeding in the stomach. Thank you very much. That's